I wanted to add just a little bit more about my rejection of the psychoanalytic model as a trainee in my psychiatric residency. It wasn't just Freud's theories, his total emphasis on the Oedipus complex and on other psychoanalytic theories that I couldn't accept, but even just the way psychoanalysis was done, that is, the patient is lying down and can't see the therapist is behind them taking notes. I knew from the beginning that's not the way I wanted to do therapy. I wanted to engage with the patient. Now that doesn't mean that you're having a conversation back and forth. That's not therapy. There is something special about being a therapist, and maybe we'll get into that later. But if you don't have the normal kind of human interaction of seeing another person, I think that while it might have been rationalized in Freud's way and by his devotees who came along later in the different ways they did it, nonetheless, it struck me as being very protective of the therapist, putting the therapist in some kind of elevated position where they don't give the kind of feedback that you give to another human being when you're engaged with them. And so I was confirmed in my own judgment in the choice I made of going to Colorado, because they were, although I got encouraged by a number of staff members to go the route of becoming a psychoanalyst because they liked my work, I never ever considered it, because I could see that's not the way, that's not the kind of therapist that I want to become. The kind of therapist I want to become, I can use my personality, I can use who I am to engage the person in a way that does not set me in this other sphere of excluding myself like that, with this almost total silence during the sessions, with these very, very carefully phrased interpretations at certain times. And I never changed my mind about that. The kind of psychotherapy that I practiced is much more flowing, much more spontaneous, but it still maintains the professional relationship where you are there for that person. You're not a friend, you're a professional helper. There are things that you can do because you're not in their life, because of your experience, because of your training. And we need those kind of people. But being a medical doctor and doing what medicine does is very, very different. And that's where we're going to go very soon. You know, one of the reasons that I'm very happy to have an opportunity to have these meetings with you, that it's not easy if you're not in these professions to really get a handle on some of these important issues that face us as a society. If you haven't been through medical training or psychiatric training, you don't have a it's not easy to know what these professions, what do they do? And how do they do it? How do they know what they know? And what are the similarities and the differences between these different professions? As a medical doctor first, and I am licensed to practice medicine in California, there's no separate license to practice psychiatry or surgery. There's different ways that you get qualified. I'm a medical doctor, but I'm a specialist in psychiatry. So of course I wouldn't try to practice in a field that's outside of my training. But I know what medical doctors do, although of course I'm not trained to be a surgeon or some of these various other professions. But as somebody who's trained in medicine and then trained in psychiatry, it's easy for me to see how psychiatry doesn't fit. But it may not, and I'm sure it isn't so easy for you. That's where I want to help you with that. And once you see why medical doctors other than psychiatrists are real, truly scientists. Of course, there is art in medicine. We're talking about human beings. Your patients are not machines. But nonetheless, you are studying as a medical doctor and treating scientifically verifiable conditions with measures which can be put in the realm, that are in the realm of science. That means verification, not just relying on individual opinion, but scientific validation. Evidence gradually accumulates to go one direction or another. New treatments discovered, new diseases understood. The way science works, that's medicine is part of it. Psychiatry does not have those things. So that's the kind of background that made it so apparent to me from the very beginning that as a psychiatrist, I was not going to be doing what doctors of the other types do, not the way I was going to practice. I knew that the drugs that were starting to come along were not being used for the reasons that were justifiable in the way that they were used by other kinds of doctors. That is, when an endocrinologist gave a patient a particular hormone that either had too much or too little, or an agent which would influence the production of a hormone, that was real medicine. But when a psychiatrist was giving drugs, it was not the same. And we will be going into that in more detail. But in trying to understand that, and my attempt to help you understand it, I want to do what I did in The Reign of Error. And that's a book that was published in 1984. It's actually written in like 81, 82. Summarized my experiences in psychiatry up until that time. So I had already seen plenty of psychiatry's growing medicalization and was not happy about it and was speaking out about it and writing about it. And one of the ways that I tried to help people understand the mistakes we were making was to say, look, let's look back at some of the things that psychiatry has done and is still doing that we now say, or well, doing less of, but things that we have done that now people can say, maybe that wasn't such a good idea. The passage of enough time allowed people to question it. The most obvious example would be, let's say, lobotomies. By the 1960s, very few people were supportive of doing lobotomies. But they didn't completely stop. A modified form, to this day, is actually still done. We'll talk about that maybe later. But I saw examples, even as a medical student, of things that were done that I found horrifying, really, because they were so obviously mistaken. Ill-advised, these are the nicest words I can use, like electric shock treatment. But in the book, I went back to a number of examples to say, let's look at the rationale of why the doctors said they were doing what they were doing. Let me just give you one example. And it's one I pick because I usually try to pick the best and the brightest, not just some bad apple, but doctors that everybody respected. They were above reproach. And there could be no better example than Dr. Benjamin Rush. Now, there are many other critics of and evaluators of the field who've used this example, but that's because it's such a good example. Dr. Benjamin Rush was a very highly regarded doctor. He was a prominent physician and so well known amongst the, you might say, the aristocracy of America, you might say, the Thomas Jeffersons and John Adams, is that he was a signer of the Declaration of Independence. He was also known as the lancet-loving physician of Philadelphia because doctors in those days used bleeding for all manner of disorders, medical conditions, behavioral disorders. And doctors didn't know, they were convinced that it helped. But Benjamin Rush was one of the most aggressive as the head of a psychiatric facility that had people with behavioral and mental problems. he had many devices that he devised. One was what he called a tranquilizer chair, which strapped the person in a chair and would allow them to urinate or defecate without getting it all over themselves, and also be bled while they were still strapped in this chair. And he was praised for having devised this thing. We would call this torture in today's world. But that's not the point to be. It's not really a criticism of Dr. Rush per se. It's really a criticism of how society can get trapped into certain points of view. What I'm really getting to is Dr. Rush was convinced that he was treating a disease. Now, let's look at what he thought and what he said, and then we're going to compare it with what we do now, and we're going to see. I'm going to tell you that in my view, we haven't changed that much. So Dr. Rush was removing blood from people who were confined in an institution. And what he said was, the reason these treatments are good is because when I do this to patients, they change. They go from being annoying and just difficult and behaviorally unacceptable and throwing their feces or doing the kind of things that we know can happen in institutions where people are so going into some state that is way beyond, whether they're angry at us or angry at the world. Whatever's happening there, we can't accept this. They change when I take this blood out of them. So he said, that tells me that the disorder that that person had is they had too much blood in their brain. Now, you might be sitting there watching me right now and snickering or laughing, but resist the temptation to be too hasty in judgment. Some pretty smart people fell into the trap of accepting this rationale. I took blood out of the brain, and they changed in a way that seems to me better. The person is calmer now than they were before I took the blood out. They don't scream at me. They stopped doing various things that were a real problem. So I think my treatment is working. That, to summarize, they had a disease characterized by too much blood in the brain. I took some blood out of the brain, and now they're better. Now, the truth, of course, is that they didn't have a disease of too much blood in the brain. The reasons for their behavior we cannot speculate about, but the institutions in those days had a variety of people, some of them undoubtedly with purely psychological problems. There is such a thing as what we call psychosis. Used to be called madness. Sometimes they call it schizophrenia. People can go crazy where they do not seem to be thinking and engaging with others in a way that is comprehensible. And it's preceded by a very painful state. We're not going to minimize those issues. We're not going to minimize the problems of society, how to respond. But as of today, there's no known medical cause, despite what psychiatry might tell you. So some of the people in those institutions, like Benjamin Rush was treating, might have had dementias, old age, syphilitic. They could have had a variety of medical disorders which can influence the metabolism of the brain. All of them might have a common. In other words, they could all show up in ways which would be characterized by behavior and apparently thinking which was beyond the pale and which led to others in their surroundings being, can't take it anymore, we must do something about it. Gets dumped on the doctors, and the doctors are desperate to do something. So with the intelligence and the training and the commitment that they had, they would do things like Dr. Rush was doing and everybody else was doing. So the point that I want to leave you with is there was a model there. First, you explain the behavior and the transparent mental state as a medical disorder, despite the fact that you don't really have scientific evidence that it's a medical disorder. Then you do something to the person, and that something can be something that they don't want. And if they don't want it, they may react to the fact that you're doing to something that they don't want. And never forget the humiliation, the degradation that is inherent in having something done to you that you don't want. Something done to your body, to your soul, to who you are as a person that you do not want. One of the things that psychiatry has been very insensitive to is the meaning for another human being, is what it means to them to have somebody do something to you that you do not want done, that you lose control. And we will be getting into eventually why I made a decision that I would no longer be a part of that many, many decades ago. But that's not for today. So Dr. Rush was doing something to his patients. In his mind, I'm sure he was convinced it was the best thing to do. He changed those patients right in front of him. He defined what he did as a treatment, and therefore the treatment led to defining what was the problem in his mind. The problem was the opposite of what he did. If he calmed the person, subdued the person in some way, that means they had a disorder which was causing the problem that he was now treating. And in the next discussion we have, I'm going to show how what psychiatry is doing is exactly the same.